It's 1:30. We'll go ahead and get started. This is the financial and legal aspects of healthcare workshop of ICBO. So this is a workshop that Barry Smith and I co-organized. We have 4 presenters with a coffee break in between the first 2 and the latter 2 presenters. And we look forward to having a lot of discussion and hopefully some future actions and coordinations on ontologies in these areas. So without further ado, our first speaker is Dr. Matthias Brochhausen. He's currently Vice Chair of the Department of Biomedical Informatics at the University of Arkansas for Medical Sciences. Matthias's talk is about legal entities and trauma care.
So thanks for having me. I'm very excited to talk to you today about legal entities representation work that has been going for actually 10 years and how that kind of like comes together with some NIH funded project work that me and a multitude of other people have been involved with. And that, interestingly enough, is all revolving around the area of trauma care. So obviously, what I'm going to present today is not something that I cooked up on my own. This is the result of multiple teams of people working together over a very extended period of time. And I will provide a list of contributors at the end. So how does that all belong together? Rights, obligations, and trauma care. And everyone who ever started to think about legal entities and their ontological representation knows that that in itself can be a traumatic experience, but that's not what we're talking about today. What we are talking about is how can we use representation of legal entities to get a better understanding of organizational structures in trauma care. And organizational structures have been on the forefront of thinking about trauma care for quite a while. So in the 1970s, the American College of Surgeons started to establish and refine the criteria to set a standard for what is called a trauma center. Trauma centers are dedicated centers to provide trauma care. The ACS today recognizes 5 trauma center levels, which differ in their organizational structure and the resources they have and the services they provide. The highest level is level 1 trauma center. Those are academic medical centers that have 24/7 trauma service. They typically have all specialties at hand that are needed to even care for complex trauma or multi-trauma patients. However, interestingly enough, even when we started these projects 6 years ago, the ways in which particular organizational parameters of trauma centers contribute to optimal patient outcomes has not been identified or measured. So this is really what initially drove the idea to look into obligations and rights that revolve around these organizational structures of trauma care. Here you have a few examples of what kind of rights and obligations we talk about. And just as a a teaser for later, I decided in this talk to start in talking in the language that we started to use at the beginning of the project, and you will see how our ontological understanding of those entities like rights and obligations led to more specific terms in a later stage. So trauma medical directors, and I'm not going to read the entire list to you, but this is a lot of those things have to do with who has oversight over what, who has the authority to add X to a specific group of people. But in itself, like the role of the trauma medical director is interesting. The American College of Surgeons, in their way of assessing trauma centers, they call that verification process. They did that nationwide, but they also ventured out into foreign countries. And then one thing that they found is that even that was really difficult because in some countries the regulatory framework was completely different from the US. So for example, in the Scandinavian country, the requirement for a person to become a trauma medical director was that they were an anesthesiologist, while in the US the requirement is that you're a trauma surgeon, which then led to problems in assessing these structures. So these differences in all of these, the fact that there was not a lot of research going into, well, take a microscope and look at the lower level organizational structures in those centers beyond the really broad strokes of what the ACS was assessing, led to the start of the CAFE project. CAFE stands for Comparative Assessment Framework for Environments of Trauma Care. And this project has now, just a month ago, well, actually starting this month, been renewed, and we changed the name to Trauma Institutional Priorities and Teams for Outcome Efficacy. So that's all new. CAFE very much just laid the groundwork for addressing the problem and enabling the representation of data about those lower level organizational structures, the different roles, the different components of a trauma center and their requirements, like the credentials that are needed to be in that role, and their rights and obligations. And those actually really differ from organization to organization. And even they differ even within level 1 trauma centers. That is what I want to stress. So it's not that we say, obviously, a level 4 trauma center differs in its organizational structure from a level 1 trauma center, but no, even among level 1 trauma centers, there's a huge difference in organizational structure. And mind you, there is also a lot of variability of patient outcomes among level 1 trauma centers. So in TIPTOE, we will now link the organizational parameters to patient outcomes, and we will provide tools for decision makers to improve patient outcomes using those insights. This is just a little bit of the funding history. So CAFE was a 5-year project with a no-cost extension for a year, and we just started the new project, TIPTOE, which is supposed to run for 4 years. So in order to give you the whole picture of how we capture the organizational parameters, I need to talk a little bit about the CAFE architecture, which is still in use in TIPTOE. The idea was that we wanted to create RDF data immediately. Like, we didn't want to set up a red cap and then transform it into RDF eventually. We wanted to create RDF data the moment we are collecting data, because we always find that this shifting from one data representation to the other is an error-prone process, which we wanted to eliminate. So what we did is we created a tool very much like SurveyMonkey, but instead of just recording the answers, it creates RDF representations of what the answers are about. And we did, based on that tool, we created a questionnaire that asks representatives of trauma centers about their organizational structures. It has all the stuff that you want in a survey. It has like a survey logic where certain questions only pop up if you say yes to another question, and all of those good things. And in order to give a little bit of motivation to the people who are filling these in, we provided real-time comparison. So this is how you compare to other trauma centers or to a specific standard. And then there is also, we will not talk a lot about that, but there was also a data visualization piece where we then provided visualization of that data. So the achievements of CAFE were that we created a shared ontology called OOST. We will not hear a lot about OOST today, because when we talk about ontology, we're going to talk about DACTS, which hosts most of the legal terms. And then OOST imports terms from DACTS. And OOST also has a shared vocabulary. We actually put a little bit of effort into validating that vocabulary with domain experts. This, and I hinted to that for those of you who were in the meeting about the FAIR standards. I hinted to that there. We found that if we give the definitions that we build in for the ontology development process, if we give that to our domain experts, we don't get good responses. So we provided, I don't want to call them definitions because I don't want to get into trouble, but we provided descriptions that are meant to be understandable and relatable to domain experts. And we tested that. We tested, is this term and this description a good fit, actually, by talking to domain experts. Okay, and we created the questionnaire that utilizes this, and we can actually see some of those things in the next slide. So I think I pressed enter rather than the button I should use. Do the people on Zoom still now see a new slide called Cafe Questionnaire?
Yes.
Yes.
Thank you. Just wanted to make sure. Okay, so this is how the Cafe Questionnaire looks to a user. You see this has many chapters, like people is mostly like specific functional roles in trauma center. And specialities is also about medical experts being part of the trauma team. The most important roles are the trauma medical director, the trauma program director, and the trauma registrar. And you see that we have this little pop-up box that shows the description of regional trauma national or regional trauma organization to the user. I want to zoom in a little bit on this green box. The green box shows you that in real-time comparison. So here, this is a really good outcome because the trauma medical director in the center that we're looking at here has all of the authorities that we could wish for, and he has some other responsibilities which all are really good. You want your trauma medical director to be on trauma call. You want the trauma medical director to lead quality improvement. And you want the trauma medical director to evaluate your trauma program manager. And the top bar shows who is the trauma medical director reporting to. This is really something where we would like to see, does the reporting structure change anything in patient outcomes? We'll find out in TIPTOE. So what has changed in TIPTOE is we changed the structure of the project from a single PI project, where I was the PI, to a multiple PI project. Dr. Sexton is a trauma surgeon and biomedical informaticist, and he joined the team as one of 2 MPIs. And we're using outcome data from multiple level 1 and level 2 trauma centers. It's important to understand we're not adding burden to those centers. All of the trauma centers report so-called TQIP data, that stands for Trauma Quality Improvement Program, to the American College of Surgeons. And the TQIP data is created in those centers anyway. They now just also need to copy it and send it to us. And this is why we're confident that we will make our recruitment goal. The recruitment goal is 230 trauma centers, and that includes both level 1 and level 2. And the organizational parameters have been restricted from over 100 in CAFE to 40. And that's important because the people who are filling in those questionnaires now are mostly people who are either running a trauma center or they are medical staff in a trauma center, and we cannot burden them with like 150 questions. So we did an initial assessment with experts and picked the most likely parameters to have an influence on outcomes. Okay, this is the list of publications that we did about CAFE, and the last one is already foreshadowing TIPTOE quite a bit. Okay, that was a long introduction, and I really appreciate you not walking out on me because we haven't talked about legal entities yet, but we're going to do that now at our heart's content. So I hope that The long introduction, however, made it clear that there are legal entities which are relevant to trauma care, and that if we want to get a full understanding of the organizational structures in that specific area of care, we need to be able to represent and discuss legal entities. So a question that is important and has been important for a long time is the question of how do rights and obligations come into existence? So I'm hearing some sound. Does someone have a question? Okay. Enrique, would you mind silencing your microphone? Thank you. I'd appreciate that. And here is a model that I'll talk at the end of the presentation. I'll give a little bit of a list of literature that we use to do this. So when we talk about rights or claims and obligation, this is how at the beginning we thought it works, and we still think basically this is how it works. So there is a process, say, for example, me signing an offer letter from the University of Arkansas for medical sciences. That process has two specified outcomes. Actually, it has more. Talk about that in a minute, but in our picture, we represent two of them. One is my role as a claimant. Once I sign it, I expect that they pay my salary every month. And the other is UAMS's role as an obligor who is obliged to pay that amount. Obviously, there's also an obligor role for me. I have to provide certain services and do specific work for UAMS. And UAMS has a claim to my work. And also, not on this picture is, this also has a signed document as a specified outcome. We're not talking about documents that, and for those of you who are not familiar with that work, the documents are really important in the sense that they get signed and that creates something, but the signed documents are not the rights or the obligations. They're just signed documents. Sometimes they do. This is a good remark. Sometimes they don't. Like when I signed my offer letter from UAMS, they say a lot of stuff. But then HR, the day after I signed, send me a whole big PDF of these are your obligations that you also have to do just by signing on, right? So those are additional. They're not always in the same document. Yeah, certain things are there, like this is the salary we will give you, this is the position, these are roughly your duties, but like the entire code of conduct that I have to follow as a faculty member, that is not in the offer letter. Which that is how. Yeah, that it does. And you know that, but that's. I think it's important that not all rules and regulations are always in the actual document. Sometimes there are references to other documents or to the general legal framework. It needs, at some point, it needs to be represented. This is just really a tiny snapshot of what happens when I sign the document. Not claiming this is exhaustive. So, okay, now we called here this me signing the offer letter a declaration, and we'll get back to declarations in a moment, but this is actually an example of what Barry calls I hope it is an example of what Barry calls a document act, where you use a document to create new entities, like my role or my claim, well, my role as a faculty member, but also my claim to a certain salary and my obligation to perform specific tasks. And this is what spawned, the Document Act spawned the development of the Document Act ontology. And here's just another example where we now use the terminology of the Document Act, and we add a new type of entity, the Document Act input document. So the example here is when CM Clancy became the AHRQ director, there was a certificate of appointment of CM Clancy in that role. That was the specified input to the director, to the Secretary of the Health and Human Services, signing of that document, which created the role of CM Clancy as AHRQ director. It also, and in this slide we have that represented, creates the signed document per se. And it also probably creates other obligations and rights like that we're silent about in this case. So this is really the heart of how many rights and obligations come into existence. There are a few alternative examples, but for today's talk, this is what we focus on, because these are mostly the things that we encounter when we take, or that we encountered when we took into consideration how do we represent trauma centers in trauma centers and their organizational structures. I think it's interesting to note that document acts are not restricted to economic entities, and we saw that in the last example. CM Clancy's role is not per se an economic thing, it's really a functional or an institutional role, and we will talk about the difference and how those differ from rights and obligations towards the end. And by and large, this is all based on the theory that there are social acts, things that we socially do that bring about socio-legal entities. I think it was, Barry, correct me if I'm wrong, I think Searle in one of his books says that they are fecund activities, where you do something and that creates new entities that come into being through this act. Okay, so already in 2012, we started to take this whole idea and implement it into an ontology. It's called the D-Acts. It's called the Document Act Ontology, D-Acts for short. It's implemented in OWL, and it's based on BFO, and it follows the OBO Foundry principles, and it reuses classes and relationships from OBI and IAO, and I assume relational ontology. This is where you can find D-Acts. It uses an IAO namespace. That is a little bit of a sour spot for me, but we are working on that.
That's why you're on the line.
For example, right now you cannot see D-Acts in Ontobi because D-Acts is in the IAO namespace. So I have a certain range of IAO identifiers that I can use. And I'm working with the OBO Foundry to relieve that issue because it is an issue. And I think there's a lot of goodwill, but there's on all sides, mine included, just a lack of time. The problem is really that when we created, I basically created D-Acts and another ontology at the same time. The other ontology was the proper name ontology, which, thanks God, as of this year, is merged back with the information artifact ontology. But D-Acts is still an open issue, and at the time, the curators of the OBO Foundry said basically those are extensions of IAO, which for the P&O was true, for D-Acts is not, because these document acts are social entities that are not, at least the declarations, if we don't even go to the documents, the declarations are not reliant on information content entity. But at the time I needed a way to get my ontology published, and you know, this is how it goes. We're still working on it years later. Yeah, but the good news is it's, I mean, on the GitHub page, you can download the OWL file, you can look into the OWL file, and of course, reuse the OWL file. And there is an issue tracker. I don't know whether some of the people who are right now having very lively discussions on the issue tracker are here today. I think they're not in the room, but this is really great. Over the last few months, we saw a lot of really lively discussion on the issue tracker of DX, and this is important for us to improve and create a better representation. So the first term that I want to discuss is the Deontic Document Act. This is what we're starting at the lower level. So this is a Deontic declaration that is doing its work, the creating or the revoking of a Deontic role by, in the right way, manipulating a document. My work contract is an example, I think, and I hope I'm not wrong. I think in an early publication we had immigrating into the United States on with a passport as an example, and I hope that was correct, because you get a stamp and then you are in and you are allowed. And the superclass to this is the Deontic Declaration. It's important to note that there were rights and obligations and legal entities before we did everything with documents. And there are still specific operations that you can do verbally. You can withdraw from a clinical study verbally. You don't need to sign a document. Your withdrawal is just as valid as if you signed a document. So that's Deontic Declaration. You revoke the Deontic role that allows someone to keep your record and to contact you and all of those good things. And the Deontic declarations are social acts. So social acts are these specific activities that obviously planned processes where we are interacting with each other, and in those processes we can create new social entities. Okay, and we published. There is a little bit of a publication curve for DX, and we are in the process of alleviating that. The problem with DX is all people who are contributing have day jobs, and those day jobs don't necessarily involve writing up DX stuff, but we need to do that. The last publication is from 2013. Since then, if you go to the GitHub, you'll see there was a lot of development. And some of that development I will talk about now. So if you look into job descriptions in medicine, in there you find a wide mixture between this is what you'll do for the institution, this is the role in the institution you will take, like for example, be the trauma medical director. But you also find rights and obligations. You will need to promote health education, right? And so typically there is a little bit of a difference between those two, and they also interact, right? Like when for CAFE, we ask questions like, what are the obligations of the trauma medical director, and what are the privileges of the trauma program manager, and all of those things. And this is why I made this changed picture from the first graph I showed, because now I factorized in that this whole process of me signing my offer letter also creates my faculty role. But my faculty role is not like a claimant role. It is in fact a different type of role. And we in DX we call those institutional roles. Those are the roles that within an organization for which the people employed by that organization are primarily hired, like physicians, nurses, surgeons, trauma medical directors, all of those good things. And they're different from deontic roles. Deontic roles are defined in DX as follows. Deontic roles are really grounded in normative expectations. obviously those two interact. I mean, there are people who also have normative expectations towards faculty members, of what faculty members should do or shouldn't do, or what nurses or doctors should do and shouldn't do. But we think that analytically, those can be kept fairly distinct. Another big piece that we added over the last few years, this is really was added last year, is we allowed for more difference in how we talk about rights and obligations. If you look into what all people mean when they say rights, you'll find that there are certain differences. And this was all written up at the beginning of the 20th century by a scholar called Hofeld. And he distinguishes claims, privileges, powers, and immunities on the one hand, and those come with opposites: no claim, the lacking of a duty, and the lacking of a disability, and the lacking of a liability. But it also comes with correlatives. So if A has a claim, then B has a duty. This is the example of my offer letter, where I have a claim. That means that UAMS has a duty to pay me my salary. And similarly, you have privileges. So if A has a privilege, that means that B has a no claim. Well, we'll talk a little bit about the no claim and no claim issues. And if A has a power, then B has a liability. And if A has an immunity, then B has a disability. So this was really important for DX because this helps us now to model things that were important to the trauma care field. I already said this is one example of this is my claim to remuneration for my trip to ICBO against UAMS. But in the trauma world, it's like, for example, Dr. Doe has OR privileges. And that is important because no one can claim that Dr. Doe cannot use or does not have access to the OR. But there's also someone who can revoke Dr. Doe's OR privileges, and that person has a power. And so this helps us to have a more stratified and, in our mind, a clearer representation of rights or things that we would call right. And I'm going to just show these roles that we added. It's the claimant role, the duty holder role, the power role. I'm flying through these a little bit because I hope you can all read them, but I also know that I'm like 5 minutes out and I want to make sure that I give some time to discussion. Okay, good. So obviously we did not create anything like no claim because that's not an ontological entity. So some of the Hofeldian theory is still not represented in DX, but we represented those things which we felt we could straightforwardly represent. And this is all of the foundational writings for all of the philosophy stuff that I was talking about. And I want to acknowledge the National Institute for General Medical Sciences, which has supported this research for a very long time. We're very happy about it. And thank you all for your interest.